دلوقتي ندعو الأستاذ الدكتور علاء نوح، الدكتور قادر السعيد، الدكتور هشام الخياط، الأستاذ الدكتور شريف عبد الفتاح.
Yes, I'm here and
Janssen Symposium.
I'm proud to be chairing this session with Professor Alaa Nouh, Qadr Saeed, and Hisham Al-Khayyat. I would like to present Professor Edward Lewis from Belgium. He graduated from Liège in Belgium, studied in his postgraduate also in Oxford. He has a very long list of CV, but at the moment he's chief of gastroenterology and inflammatory bowel disease in Liège. Please, Professor Edward Lewis, start.
So, good afternoon, everyone. I'm very happy to be with you today for this symposium. So I'm going to share my screen. Hope it will work. We'll just tell you, you just tell me if it works.
Yes, it works. It works.
It is very clear now.
Okay, you can see it?
Yes.
Okay, excellent. So the topic of my talk today is about histology as a target in ulcerative colitis. So you perfectly know, I think, the concept of the treat to target and its relevance. It has been introduced, I would say, 5 years ago by this very landmark paper from the IO-IBD. And it really changed our practice over the last 5 years. The important thing is that it is now very important to set up a target at the start of a therapy with any kind of patient with IBD. And this target is actually a dual target. It means that we should at the same time improve patient symptoms and also intestinal healing in IBD. This is a concept that is here for stay. I'm sure that in 10 years' time, we probably will still use the treat to target concept. What will change and what has already started to change is actually the definition of the target. As you see here in the initial publication, for example, for ulcerative colitis, the target for symptoms was, of course, no symptom anymore, but the target for a tissue healing was an endoscopic Mayo of 0 or 1. And this is the thing that I would like now to challenge. I think that still reaching Mayo 1 endoscopically is a very good endpoint and a very good outcome for the patient, but it's maybe not the ultimate. And with new treatment strategies, we may maybe be a bit more ambitious. But first, why is it important to have this dual target and not only looking at patient symptoms? Simply because just like in Crohn's disease, in ulcerative colitis, there is a discrepancy between endoscopic and even histologic healing and the symptoms. You see that in a recent paper published by the New York team from Jean-Fred Colombel, that actually among patients having endoscopic healing as assessed by the endoscopic Mayo score or even histologic healing, you see a significant proportion of patients still having rectal bleeding or an increased stool frequency. And obviously you see here that in Mayo 1, endoscopic Mayo 1, you see up to 1/4 of the patients still having some rectal bleeding and up to 1/3 of patients having still increased stool frequency. So that's why, because of this discrepancy, we have to assess our patient both ways for the symptoms and for the intestinal healing. And the other aspect is that reaching intestinal healing, reaching colonic healing here has been something which has been associated with better outcome for a long time now. You see this very well-known population-based study from Norway, where actually the authors were able to show that when the patients were reaching mucosal healing, after 1 year of therapy, within 1 year after diagnosis, you see that the colectomy rate was significantly lower. And actually, this is something that has also change our practice. And at that time, mucosal healing was defined by an endoscopic Mayo of maximum 1. But the thing that I would like now to highlight is that the target is now moving. We have a moving target, and particularly for tissue healing. For the control of symptoms is always the same. It's the best we can, suppressing and alleviating a patient's symptoms. But for the intestinal healing, there is a lot of debate, both in Crohn's disease and ulcerative colitis, and particularly here in ulcerative colitis, there has been a change in the way we see things. So if you look here in the first studies on that topic, which are back to, I would say, 7 to 10 years ago, you see that there was a clear demarcation between patients reaching what was called at that time endoscopic healing with a Mayo endoscopic score of 0 or 1, and patients having Mayo endoscopic score of 2 or 3. And this was under anti-TNF therapy. And you see that patient reaching endoscopic Mayo 0 to 1 at much less colectomy rate as compared to the one not reaching this endoscopic healing. And this has been confirmed in several studies, but more recently, we saw studies highlighting the fact that if you look at patients having reached Mayo, endoscopic Mayo of 0 or 1, and if you try to separate them, you see then a difference in the outcome, which is actually the fact that patients reaching Mayo 0 will have over time less frequent relapse as compared to patients reaching Mayo 1. And it is not only for relapse, it is also for colectomy. In this other study coming from Nancy, you see that actually patients having an endoscopic Mayo score of 0 had less colectomy over time in routine practice patients as compared to endoscopic Mayo score of 1. So this was highlighting the fact that maybe beyond endoscopic Mayo 1, we should maybe try to reach endoscopic Mayo of 0. And then when you go beyond, you start thinking, okay, but what about histological healing? And when you look at these data about histological healing, at least in retrospective studies, and I will first show some retrospective studies, you see that histologic healing has been associated with a series of improved outcome, which is actually less symptoms, less relapses, but also a reduced risk of hospitalization, of colectomy, surgery, and a reduced risk of colorectal cancer. So this is all in retrospective studies, and obviously there may be some bias in it, but still this is suggestive that maybe we should go again beyond simple endoscopic healing and try to target histologic healing. This is one of the first prospective study which tend to confirm this. This is coming from Oxford, from the team of Simon Travis. And what they did actually, they treated patients with a flare of ulcerative colitis, mainly with corticosteroids in that cohort of patients. And after the treatment of the flare, they just assessed their patient by endoscopy, but also they took biopsies. And what they could show is that when the patients were in clinical remission, whether they were in endoscopic healing or not, and they choose here for the definition of endoscopic healing a Mayo and not endoscopic Mayo score of 1 as a limit, as a threshold, they could show that there was no difference in the coming months and years as far as the steroid use and the occurrence of acute severe colitis. While actually when they looked at histology, they could show that patients reaching histological remission at that time after the steroid course had a decreased use of corticosteroids in the coming months and years, and also a decreased occurrence of acute severe colitis. So it just highlights the fact that after a simple course of corticosteroids and in patient in remission after this course of steroids, reaching histological healing, histological remission could be a better outcome than simply reaching endoscopic healing. But then you would say, yes, but how to define histologic healing? Because there were several definitions that were proposed, and gastroenterologists themselves were not necessarily very interested into that. So should we involve our anatomopathologist, and how to deal with that? This is a complicated slide for a complicated problem, because actually the histologic score which has been most used for a long period of time has been the Gebo score. Gebo score, which was actually created by one of my colleagues in Leuven in Belgium, a colleague from Paul Rutgers. And actually, it was a very nice score, but very complicated and not easy to use. As you see here, there were actually a series of domains, actually 7 domains: architectural changes, chronic inflammatory infiltrate, acute inflammatory infiltrate, eosinophils, and so on and so on. And for each of these domains, there was a scale, a series of grades from actually 0 to, depending on the criteria, 3 to 4. And you see that at the end, you don't have a numerical value. You have a series of domains with a series of grades, which is not always easy to use. But then there were several studies highlighting the fact that among these domains, the most important and the ones which were most correlated to endoscopy, for example, or to disease outcome or to symptoms, were these 3, which is actually neutrophil infiltration of the epithelium, crypt abscess and destruction, and presence of erosions and ulcerations. So those are the 3 most important items from the Gebo score. And when you create a new score with these one, you have quite a nice correlation with different symptoms and outcome and endoscopic appearance in ulcerative colitis. And actually, interestingly, the first validated histological index is now available, has been published a few years ago by the team in Nancy from Laurent Perrin-Biroulet. And actually, interestingly, those are the items that are taken in that score. And you see, it's like an algorithm, but very easy to use. If you have ulceration, obviously you are not in histologic remission, you are having a grade 4. If you don't have ulceration, but you have acute inflammatory infiltrate, which is actually infiltration with neutrophils, then you have grade 3 or 2, depending whether it's moderate or mild. And then if you don't have ulceration and you don't have acute inflammatory infiltrate, so no neutrophils, then you may still have some chronic inflammatory infiltrate, including lymphocytes and some architectural changes. And then you are in remission. So for Nancy score, the threshold for remission is grade 0 or grade 1. Grade 0 is everything normal. Grade 1, you have some chronic inflammatory infiltrate, but no neutrophil and no ulceration. This is currently, I think, the easiest histologic score to use. And it's mainly, as you see, based on neutrophil infiltrate. So that's very interesting, because if you don't have pathologists interested in IBD, or if they don't want to go into that, you have then a fantastic biomarker, which is correlating actually very well with the neutrophil infiltrate, which is fecal calprotectin. As you know, fecal calprotectin is actually correlated to calprotectin in the neutrophils, in the lumen and the colonic mucosa, because calprotectin is the protein that represents 60% of the protein of the cytoplasm of the neutrophils. So it means that when you have a lot of neutrophils in your epithelium and in your lumen, you will have an elevation of the fecal calprotectin. And you see here that the fecal calprotectin correlates very well with endoscopic score of ulcerative colitis, the UCEIS, and also histologic score like the Nancy score. But what you see here also is that if you want to get a threshold indicating endoscopic remission in ulcerative colitis, you should take a threshold which is around 180, while if you want to reach histologic healing, is probably below 100. So what we have learned also with fecal calprotectin is that the threshold we have to use depend on the degree of healing that we want to reach. But clearly, this is a marker also which is here to stay, and which represents not only endoscopic healing in UC, but also histologic healing. Now, to go a bit beyond, as we have showed now that we have tools to assess histologic healing, I would like to come back to the relevance of this histologic healing. I showed you that we have several retrospective data highlighting the fact that indeed histologic healing may be associated with less complication, less cancer, and so on. And indeed, cancer is one of the main issue here. I think that if you can reach histologic healing in those ulcerative colitis patients, we may indeed decrease the risk of cancer in these patients. And you very well know that this cancer risk exists in these UC patients, and you see here meta-analysis. Sorry, I don't know where it comes from, but so you see that these meta-analyses indicate that indeed there is an increased risk of colorectal cancer in ulcerative colitis patient, and this relative risk is around 2 to 3, between 2 and 3, highlighting this real risk, and which is actually associated with ongoing histological inflammation. And this risk has been more recently reassessed, and indeed we can say that over the last 10 to 20 years, probably thanks to the way we are managing IBD today, we have decreased the risk of colorectal cancer, but still, it is still a relative risk of 2 to 3, with around 2.7% of the patient having colorectal cancer after 20 to 30 years of evolution. And this risk is higher when you have a pancolitis and obviously when you have ongoing inflammation. But this is not the only aspect which is important when reaching histological healing. The other aspect is fibrosis. So fibrosis is very well known and documented in Crohn's disease, where it will lead to a stricture. And it is less well known in ulcerative colitis simply because you usually don't have stricture in ulcerative colitis. Although you may have stricture in UC, when you have a stricture in UC, it's always suspect to be a cancer, and usually inflammation doesn't give rise to stricture. But it still gives rise to some tissue damage. And this is a very nice study published 2 years ago on around 90 surgical specimens of colectomy, highlighting the fact that in those specimens, most of them, 100% actually of them, got submucosal fibrosis. So there is no stricture simply because the fibrosis is only in the mucosa and the submucosa. But as we are going to see in a moment, it has also consequences on the function of the colon. And what you see in this histogram is that actually when you have patient in blue here with no inflammation, there is almost no fibrosis. When you have only acute inflammation, you have less fibrosis, and it's when you have chronic and acute inflammation that you, and particularly both of them, that you will get more fibrosis, and then you will find a lot of area with fibrosis when you have active inflammation and chronic mucosal injury. Why is mucosal and submucosal fibrosis important? Because it will disturb not only colonic motility, but also colonic absorption. And you see here that actually UC is characterized by decreased motility, reduction in the pressure or amplitude of the segmental contraction, and variability in the behavior of propulsive waves. And so you see that you will actually alter the functioning of the colon, and that may explain some of the symptoms we see with chronic ulcerative colitis that may be either constipation or diarrhea. And what you see when you study this patient with fibrosis in the submucosa and the mucosa, you see that they will also have an alteration of their interstitial cells of Cajal, which are actually the pacemaker of the colonic motility, and you see that there is a decrease of these cells in the different layers of the bowel wall, of the colonic wall in ulcerative colitis. And this is probably having an impact on the motility of the colon. The other thing which is affected by this fibrosis is actually the rectal compliance and the anorectal function. You see here in this small study that actually patients with ulcerative colitis, being either in active disease or even quiescent, they had actually a disturbed anorectal function, and they had actually a decrease in the maximum volume tolerated in the rectum, and that would lead to fecal incontinence, urgency, and symptoms like this. So this is clearly linked to chronic inflammation and to the fibrosis that may alter the quality of the colonic tissue and of the rectum. The last question I would like to tackle is to be consistent and coherent. We should be able to show and prove that indeed histological healing can be achieved with the current drug. Because if we have a target which we cannot achieve and which we cannot reach, then it's useless and is just a source of frustration for the physicians and for the patient. But actually, histological healing can be achieved. This is a study here made with patients treated with 5-ASA, multimatrix 5-ASA in the Momentum trial, and they looked actually at the different stages of remission: clinical remission, endoscopic healing, deep remission, histological remission, and histological remission plus within the patient with endoscopic healing. So what they show here is that all the patients who were in healing had a lower value of fecal calprotectin. This is just confirming what as I told you, which is the fact that in ulcerative colitis, fecal calprotectin is a very good marker of healing, and not only endoscopic healing, but also histologic healing. But look at the number actually of patients having histological remission. You see that actually 284 out of roughly 600 patients had histological remission. So with 5-ASA in mild to moderate colitis, because those are the patients treated with 5-ASA, half of them will reach histological remission, and this is usually associated with better outcomes. So this is something that can be reached with our treatment. And again, with 5-ASA, you can also optimize the level of healing that you get. This is an interesting study which was made in patients treated with 5-ASA, but still having an increase in their fecal calprotectin above 200. And these patients were randomized between continuing the same dosage of 5-ASA, which is around 2.4 gram, and increasing to 4 to 4.8 gram of mesalazine. And what you see is that in the patient who increased the dosage of mesalazine, you have many more patients reaching level of healing which are better. And you see here, for example, I told you earlier that patient below 100 microgram per gram of fecal calprotectin at usually histologic healing. And you see that when you increase the 5-ASA dosage in that population, you reach 50% of them reaching a level of fecal calprotectin below 100, while actually there were only 15% when the dose of 5-ASA was 2.4 grams. So we can simply, by increasing the dose of 5-ASA, increase the proportion of patients with low fecal calprotectin and having a lower risk of relapse, but also most probably, although it was not studied in that study, having also more histologic healing. And this is also showed in this study, which really did the same. And again, the threshold here was 300 microgram per gram, but you see that the patient who had escalation in the 5-ASA dosage when they were still having elevated fecal calprotectin despite clinical remission, they had less relapses and they improved their outcome, probably in correlation with also better histologic healing. What about more refractory patients and patients treated with biologic? Actually, ustekinumab development program and the UNIFY program with the phase 3 trial with ustekinumab in ulcerative colitis was the first which included an histological healing assessment in the endpoint of the trial. It was not obviously the primary endpoint, but it was one of the predefined secondary endpoint. And what you see here is that among the patients who were responding to ustekinumab induction, you see that the one who went to placebo after roughly 1 year, 1/4 of them were still in histologic remission, while the one who were maintained with ustekinumab every 12 weeks or every 8 weeks, with every 8 weeks maintenance, you had up to 46% of them who were in histological remission, so with a low level of neutrophil in the mucosa after 1 year of treatment, which is actually very reassuring, highlighting the fact that in a substantial number of patients, indeed, with the drug we have today, we can reach histologic healing in a relevant proportion of patients. And again, in the same trial, I wanted to show you the evolution of fecal calprotectin, because I think it is very convincing. And you see that the patient who got ustekinumab induction, IV induction, all of them actually, most of them, sorry, decreased their fecal calprotectin. And you see that the value, the median value went from around 1,400 or 500 to 300 to 400, which is a huge decrease over 2 months. And then what you see here is that the patients were put on placebo. Progressively, the fecal calpro was increasing, and that's why in that population, you only had 24% of them in histologic healing after 44 weeks of maintenance, while in the patients who were maintained with every 12 weeks or every 8 weeks ustekinumab, you get a median calpro, which is around 200, with a proportion of them probably being in histologic healing, as highlighted by the previous slide that I have showed you. So in conclusion, my point here is that treat to target strategy is certainly an appropriate strategy for ulcerative colitis. It is here to stay. And that in the initial paper published in 2015, the target was to reach symptomatic remission with PRO2, and PRO2 in ulcerative colitis is actually stool frequency and rectal bleeding. And so we should get rectal bleeding at 0, so no rectal bleeding anymore, and stool frequency at a maximum of 1, which is corresponding to up to 2 more stools as compared to normal. And endoscopic healing, which was actually defined in that publication as maximum of Mayo 1, so including Mayo 0 and Mayo 1. But what we are doing now is that we are moving towards endoscopic Mayo 0 or histologic healing or improvement, of course, when it is feasible. And sometimes you may have some patients who do not reach histologic healing despite optimized therapy and so on. And so what I want to say today is that we should not try to absolutely reach histological healing in all patients, because in some patients we will not be able to reach it, and we still have to treat this patient. But I would like to say that in young patients, for example, with pancolitis, where the risk over the long time of disease history is quite high to have a colorectal cancer or fibrosis that will lead to defunctioning of the colon, I think it's more important than to be more ambitious with our objective of therapy in this subgroup of patients. That is something certainly we could discuss in the question and answer after my talk. So histology may be partly replaced in the future by surrogate markers like fecal calprotectin. And I think it's a very good news, because sometimes it's not easy to get a good assessment by a motivated pathologist, although there are, of course, in many hospitals, very motivated pathologists. But still, the fecal calprotectin implies that actually you don't necessarily need to do an endoscopy with biopsies, because actually fecal calprotectin below 100, for example, is most often very well associated not only with endoscopic healing, but also with histologic healing. So that's a very good marker to help us to monitor our patient and to reach our targets. Histologic healing, as I've showed you, can be achieved already with current drugs, including 5-ASA in mild to moderate patients. And the UNIFY program with ustekinumab in ulcerative colitis was actually the first to include histologic endpoint as a secondary endpoint in a phase 3 UC trial, and showed that actually with ustekinumab induction, and every 8 weeks maintenance, for example, close to 1/2 of the patient would actually, after 1 year, reach histological healing of their disease. So this was the purpose of my talk, and I'm very happy now to take any question that you would have.
Any questions, Professor Adri?
Very nice presentation and a comprehensive talk. I think calprotectin will take the upper hand because usually we don't have a comprehensive histopathological report stating the Nancy index for each patient. Usually we have the histopathological report mentioning the acute inflammatory cells and chronic inflammatory cells, but definitely we don't have a comprehensive histopathological report stating the Nancy index. I think depending on calprotectin will be much easier for us as a clinician and to guide our therapy.
So thank you for this remark. So I fully agree about this, and it's indeed my practice. Just one point about histology. The big advantage of the Nancy index is that I think it has made histological assessment almost feasible, or at least we can interpret the report of the pathologist, because as you saw, actually, if the pathologist doesn't describe any ulceration, and if the pathologist doesn't describe any neutrophil infiltrate or very small neutrophil infiltrate, you can conclude that your Nancy index would be below 2 and would be 0 or 1. So it means that as compared to the Goebbels score, which was impossible to use for gastroenterologists, and even looking at the report of the pathologist, make any conclusion was not easy. I must say that nowadays, when I look at the report of my pathologist, if I see that there is no ulcers, no ulceration, and that there is no neutrophil in the epithelium, I'm quite confident that probably it is histologic healing. But I fully agree with you that it's even more comfortable to have the calpro to confirm that by being below 100 or 150 at least.
There's a question from Professor Hani Shab. Professor Hani Shab.
Yes, Dr. Luis, lovely.
Professor Hani Shab.
Yes, can you hear me?
Unmute your microphone.
Yes, can you hear me now?
Yeah, no,
yes,
it's better.
We hear you now.
Yeah.
Yeah, Dr. Luis, thank you very much. Lovely to see you again. It's really nice to have this lovely target of the perfect ending for a patient with histologic remission. But in real life, when do we actually have to escalate? For example, I have this patient who is 30-year-old ulcerative colitis. She's doing perfectly fine on Remicade and Imuran. She 1 motion per day. She does her activity. All is fine. However, she has Mayo score of 1 and calprotectin of 180. Would I tell her, no, this is not good enough, we'll have to change or go to another biologic, or do we just let her be?
Thank you for this remark. I mean, this is a very, very important point and very practical one. And I fully agree with you that there is no easy answer to that question. I would say that the youngest the patient and the more extensive the disease, more ambitious I will be with the target, which means that if I have to give you 2 different examples, if I have, and I will come back to your specific example in a moment, if I would have a patient who is my age, let's say 55, with a Mayo 1 and just a proctosigmoiditis, and he's fine, I will not change therapy. If I have a young patient who is 18 with pancolitis and still having Mayo 1, I may be a bit more anxious and try to increase therapy. Just to explain you that indeed I fully agree that we have to adapt this principle to every individual patient. For your patient who is 30 and having already a combo therapy with infliximab and purine, and doing fine. I think that the only thing that could be discussed is to measure trough level of infliximab to see whether we could maybe increase the dosage of infliximab. But I fully agree with you. I wouldn't change completely the treatment, because the risk that you would take is that if you change completely your treatment, the patient may not respond as well as he responded or as she responded to infliximab and purine, and then you may have a flare, and sometimes in UC these flares may even go to colectomy. So we have to be very careful, but I think that here probably measuring drug level, and if they are low, maybe contemplating going to every 4 weeks or something like that, or 10 milligram per kilogram, and try to see whether you reach a better level of healing, maybe something useful for the patient, I would say. But indeed, I fully agree with you. It has to be adapted and discussed to every patient.
Thank you. Thank you. It makes sense. Yeah.
Thank you very much, Professor Luis. We, for the sake of time, I think we have to go on with the program. But thank you very much. That was very informative and very enjoyable. Thank you.
It was very great pleasure, and I'm very happy to have been with you and have a nice meeting now. Thank you.
The next session, will they take over, please?
Yeah. دكتور. أيوة.
Yes, please start the next session.
Exactly, and welcome for all of you. Next session will be presented by سامعني؟